Hi everyone, this is our presentation for prevention and rehabilitation of complex chronic conditions. We're group 4 and the complex chronic condition that we chose is systemic lupus erythematosus. The outline for our presentation is the following. We will begin with an introduction. What is systemic lupus erythematosus? A background, how is lupus a complex chronic condition? The epidemiology of systemic lupus, the characteristics and symptoms, so what are the main characteristics and symptoms of SLE, the complexity, what is one aspect of systemic lupus that makes it complex, the rehabilitation strategy or program, so what strategy or program addresses disabilities secondary to lupus, and finally, the research. We will be examining the effectiveness of that strategy or program. Lupus is a systemic autoimmune disease, meaning that the body's immune system attacks its own tissues and organs. Inflammation due to lupus can affect many different systems, including joints, skin, kidneys, blood cells, the brain, heart, and lungs. The signs and symptoms of lupus often mimic those of other ailments, making systemic lupus difficult to diagnose. Let's start with the definition of a complex chronic condition given to us in class. The definition is according to the Ministry of Health and Long-Term Care and states that chronic diseases are long-term diseases that develop slowly over time, often progress in severity, can often be controlled but rarely cured, may significantly impair everyday physical and mental functions, and reduce one's abilities to perform activities of daily living. To begin, there is no cure for lupus. However, treatments, which will be discussed later on in this presentation, can help control symptoms. Lupus is a long-term disease that develops slowly over time and can progress in severity. People with systemic lupus erythematosus are at risk of developing cancer. The most common cancers associated with lupus are blood cancers such as leukemia and lymphoma, and breast cancer. Also, people with SLE are at risk of heart disease, to be more specific, coronary heart disease. Without a doubt, any chronic disease will take a toll on both mind and body. Some physical impairments include weight gain, rashes, ulcers, changes of the skin color in the extremities, pain, fatigue, etc. These visible symptoms can cause insecurity, self-esteem issues, and depression. The chronic physical symptoms take their own toll on the mind as well, leading to frustration and a feeling of hopelessness. To continue, physical limitations, such as pain, can cause difficulty sleeping, which creates the fatigue cycle that makes completing daily tasks challenging, such as work and other free time activities. Other areas that are effective are the following: difficulty with family and close personal relationships, worrying about the future, anxiety, fear, and stress, cognitive dysfunction, forgetfulness, and moodiness and/or changes in personality. As we can clearly see, systemic lupus erythematosus fits the MOHLC definition of a complex chronic condition.
Epidemiology of lupus is on the rise. The underlying causes of the disease are not clear. The most at-risk populations identified by the statistical evidence are women of childbearing age. The effect of hormones may play a part in the cause of SLE. Furthermore, lupus is more commonly found in African Americans, Hispanics, and Asians than Caucasians. The effect of environmental factors may also play a part in the incidence of SLE, since cases are more often found in cities around pollution than rural areas. The incidence rates of SLE are also on the rise due to advances in healthcare screening technology. This leads us to believe that SLE is a dangerous disease which targets a sensitive population with severe outcomes and is also on the rise. This slide represents the amount of people affected by SLE per 100,000 person years. As you can see, the more affected populations are females from 25 to 65 plus.
SLE is characterized by a global loss of self-tolerance caused by the production of pathogenic antibodies directed against the binding proteins of nucleic acids. Anti-nuclear antibodies with nuclear antigens can form in the tissues, causing inflammation to intensify due to cytokine production. These antibodies are autoantibodies that have the capability to destroy structures within the cell's nucleus by binding to them. The release of nuclear antigens is a consequence of cell death. This diagram describes the pathogenesis and main characteristics of SLE. As you can see on the top of the diagram, environmental triggers, multiple genes, neuroendocrine system, and sex hormones contribute to immune dysregulation. Further specific cells involved are also shown, such as excess T cell help, B cell suppression, which further lead to the production of autoantibodies, and finally, leading to tissue injury and damage. Lupus Canada states SLE to be known as a disease with 1,000 faces because the symptoms change over time and vary from person to person while also mimicking many other diseases. All the symptoms can occur at onset of the disease or at any other time, which can be specific and non-specific to lupus. Non-specific symptoms include fatigue, being the most frequent symptom, continuing and unexplained weight loss and/or weight gain, fever, and slightly swollen lymph nodes. Specific symptoms to lupus involve many other organs of the body, and to distinguish the difference between lupus and other diseases, a list of 11 abnormalities have been created by the physicians of the American Rheumatism Association, and to make the diagnosis of SLE, at least 4 out of the 11 abnormalities need to be present. The 11 criteria is as follows. Number 1, the butterfly rash, which is the red rash that occurs over the cheeks and the bridge of the nose. Number 2, photosensitivity, which is the skin's reaction to sunlight. Number 3, discoid lupus, which is a scaly rash that appears on the face, scalp, arms, or chest. Number 4, muscular ulcers, which are sores that occur on the mucous lining of the mouth and nose. Arthritis, which is number 5 and causes pain in the joints. Number 6, pleuritis, which is inflammation of the pleura, lining of the lungs, and pericarditis, which is inflammation of the lining of the heart. Number 7, kidney involvement, ranging from mild to serious. And this is really important to detect early because it is what causes the most deaths in SLE patients. Number 8, seizures and psychosis caused by the central nervous system. Number 9, disorders of the blood cells, causing autoantibodies to attack the blood cells. Number 10, immunologic disorders, which refers to 4 antibodies that are found in the blood. Number 11, anti-nuclear antibodies, which are present in almost every patient with SLE. This slide lists some of the symptoms that indicate a flare of SLE, for example, fatigue, weakness, loss of appetite, fluctuations in weight, sores on the roof of the mouth, unexplained rashes on the body, persistent hives, pain in the joints, and chest pain.
SLE is a very complex disease. It is an autoimmune disease that mainly affects women and typically has manifestations in multiple organs, such as the skin, kidneys, heart, lungs, brain, joints, and etc. Manifestation to these multiple organs yields in multiple organ damage, failure, and/or formation of other diseases. As we have learned from our previously presented class material, complexity of a chronic disease is classified by recognition of 3 main factors. 1. Comorbidity, multimorbidity, polypathology, which refers to the existence of 2 or more diseases. 2. Healthcare utilization refers to patients who frequently visit medical clinics, specialists, hospitals, and have elevated drug use. 3. Psychosocial and environmental factors, such as education, income, employment, and other factors. The complexity of these diseases ranges from end-stage renal failure to formation of cardiovascular diseases, stroke, osteoporosis, infections, and psychiatric disorders. Patients with systemic lupus erythematosus have an extremely elevated burden of comorbidities. There were several research studies conducted in relation to complexity of SLE as a chronic condition or a disease. However, one of the main studies that was conducted was a retrospective cohort study using the UK Clinical Practice Research Data Link, and prevailing cases of SLE were matched by age, sex, and practice to 4 controls. The incidence of cardiovascular disease, stroke, end-stage renal failure, cancer, osteoporosis, and infections were calculated for 1,000 person-years during the study period and compared to controls using the Poisson regression to obtain incident rate ratios and Charlson index score.
Rehabilitation strategy. Through the use of corticosteroids, immunosuppressive therapy, and early detection of disease, the survival rates in patients who are diagnosed with SLE has significantly increased. Drug treatments include nonsteroidal anti-inflammatory drugs, used for patients with SLE who have mild arthritis, fever, arthralgia, myalgia, and serositis. Hydrochloroxyquine is an anti-inflammatory and has immunomodulatory properties. It allows for a slow progression towards the need of more intense treatments through reducing low-grade flares. This drug has a cardioprotective property since it reduces the total cholesterol, triglycerides, and low-density lipoprotein by 9 to 11% when combined with steroids. This is highly beneficial to patients with lupus since they have a higher cardiovascular risk. Corticosteroids is an anti-inflammatory property in the short term and immunosuppressive action in the long term. Inflammatory skin rashes can be treated through topical steroids, steroid injections for joints and localized soft tissues, and IV pulse therapy can be used for serious manifestations of SLE. The short-term benefits are to treat and prevent flares. Immunosuppressive therapies are used to reduce the amount of steroids that are administered, as well to reduce organ damage and inflammation in patients. Azathioprine is used for mild to severe disease states. It is also a steroid-sparing agent. As well, there is cyclophosphamide, which is to reduce pathogenic autoantibodies from producing through causing cell death of B and T cells. The best results is used through IV pulse therapy. Preventative measures. With survival rates improving, the risk of developing comorbid conditions increases. For example, cardiovascular disease develops early in people with lupus in comparison to the general public. There needs to be surveillance on these patients for things such as hypertension, dyslipidemias, premature arteriosclerosis, osteoporosis, and diabetes. It is also recommended that patients of lupus should wear protective clothing from the sun and use sunscreen against UVA and UVB. Additionally, infection is more common for people with lupus, therefore infections need to be treated immediately.
The research publication that will be examined throughout the next section of this presentation is Contemporary Treatment of Systemic Lupus Erythematosus, an update for clinicians. This research was published in July of 2010 by Therapeutic Advances in Chronic Diseases. The authors of this publication are Manby, Amisha Arthur, and Caroline Gordon. This publication is a systematic review which uses the accumulation of existing studies. To be included in a systematic review, these studies must have a high level of validity. This study shows high levels of evidence on the effectiveness of the healthcare interventions related to SLE. The prevalence of SLE is 28 to 60 per 100,000 people. Mortality rates 20 to 30 years ago were 50% within a 5-year period. Effective treatments are responsible for 80% of 20-year survival in SLE. The milder diseases usually compromise mucocutaneous and musculoskeletal manifestations. Severe SLE requires intense immunosuppressive treatments called induction therapy. Induction therapy is used to halt ongoing systemic inflammation and to induce remission by controlling immunological activity. With treatments moving from conventional drugs such as hydrochloroxyquine and corticosteroids, also nonspecific immunosuppressants, to target selective component drugs which increase efficiency, tolerability, and safety profile, including antibodies that deplete B cells, also with fusion cells that block the pathways for B and T cells. New developments are proving to provide less toxic and more effective treatments compared to those that are considered standard treatments. There are 3 main treatments used for SLE. These treatments are known as nonsteroidal anti-inflammatory drugs, or NSAIDs, hydrochloroxyquine, and corticosteroids. The next portion of this presentation will look at the effectiveness and critique the flaws of these treatments. NSAIDs are effective because they are helpful for symptomatic management. However, there are many critiques when using NSAIDs. NSAIDs do not have any immunosuppressive properties, and there is little evidence that demonstrates safety and efficacy. These drugs should only be used short-term, especially when there is renal involvement, hypertension, and heart disease. Hydrochloroxyquine is a common choice drug because of its anti-inflammatory and immunomodulatory properties. It is most useful in management of mucocutaneous, musculoskeletal, and constitutional symptoms. It has cardioprotective properties working to reduce total cholesterol. It is also considered to be safe in pregnancy. However, when using chloroquine sulfate and phosphate, there is a high level of ocular toxicity. Corticosteroids have effective properties that help with anti-inflammatory and immunosuppression. Both prednisone and prednisone are safe in pregnancy as less than 10% crosses the placenta. There are multiple forms of corticosteroids, but IV therapies have proven to be a more effective measure when patients do not respond to these therapies or they have serious SLE manifestations. Physicians commonly stop steroid reduction and await for clinical manifestations before they increase the doses due to the toxicity of the steroids. However, there are also major complications associated with the use of corticosteroids. These include fluid retention, blurred vision, and infection. There are also gradual effects that include weight gain, steroid-induced diabetes, osteoporosis, and avascular necrosis. They also contribute to premature atherosclerosis because of the metabolic effects on the body, such as body fat distribution, blood pressure, and glucose metabolism. Immunosuppressive therapies are generally used on patients who have a mild to severe case of the disease and they require 10 milligrams of prednisone a day to manage the disease. Immunosuppressive agents are often combined with other treatments to reduce steroid requirement, reduce inflammation, and organ damage. Azathioprine is often used for the induction of remission and steroid-sparing agents for patients with mild to moderate severities of this disease. This treatment suppresses natural killer cell activity through the effects it has on cell-mediated and humoral immune responses, which causes inhibition of lymphocyte proliferation. An issue with azathioprine is that it causes gastroenteritis issues such as nausea, vomiting, diarrhea, and it can also lead to drug withdrawal. Cyclophosphamide uses IV pulse therapy as it has shown better efficacy and toxicity ratio compared to that of oral therapies. Cyclophosphamide has slowed progression of end-stage renal failure. A study conducted showed that 18 out of 19 patients who received this therapy had improved neurological symptoms. However, it does have high alkalining agents which causes cell death, and it must be avoided during pregnancy. Side effects include nausea, hair loss, ovarian failure, severe infections, and many more. Mycophenolate mofetil, or MMF, exerts immunosuppressive effects that work to inhibit B and T cell proliferation effects. MMF has been used to prevent transplant rejection for 10 years. This therapy is as effective as IV cyclophosphamide when inducing remission and maintaining therapy in patients with lupus. MMF is effective in the reduction of both renal and non-renal lupus. However, there are a couple of flaws with MMF. The first is that patients are strongly recommended to avoid it when pregnant, and it is also unlicensed in the use of SLE. There are many novel therapies when treating SLE. These include rituximab, epidemiology, inhibition of B lymphocyte stimulator, and abatacept. These monoclonal antibodies target several surface molecules on B cells that are developed to reduce the formation of autoantibodies. In a clinical study, rituximab made significant improvements in patients with at least one lupus manifestation. 91% of the patients showed therapeutic response to the treatments and its response to their B cells. Epidemiology is an attractive treatment to SLE patients as it reduces the presence of hyperactive B cells by 30 to 45% without affecting T cells. Inhibition of B lymphocyte stimulator was tested on patients with active SLE and failed to reach primary endpoints as they reduced circulating B cells by 50% and anti-dsDNA antibodies by 30%, which caused an end result of no decrease in disease activity. Abatacept is known for effectively suppressing T cell activation. Overall, this systematic review effectively demonstrates the levels at which treatments work to enhance and maintain the lives of individuals with lupus. Each treatment therapy shows effective properties, but also properties that could be harmful to the patient, which should be improved upon. The main licensed SLE drugs are corticosteroids, hydrochloroquine, and azathioprine. Unfortunately, long-term use of these is not appropriate since toxicity is a concern with such drugs. Therefore, developing more drugs for treatment of this disease that have lower toxicity levels would be highly beneficial, such as MMF and azathioprine. This is why the combination of licensed SLE drugs and immunosuppressive therapies are the ideal therapy option for individuals with lupus, as they reduce steroid requirement, inflammation, and organ damage.